Dr. Vahidy is an associate professor at Houston Methodist and the Weill Cornell Medical College. He's an associate director of the Center for Outcomes Research here at Houston Methodist. He holds the inaugural Conway Family Centennial Endowed Directorship in Quality and Outcomes, and he also serves as the Division Chief of Population Health Sciences and Health Services Research in Center of Outcome Research.
Thank you so much, Dr. Ahmed, for that kind introduction. It's always been a pleasure, and I'm also equally happy that we both are again at the same institution and keeping on with our collaborative work. I would be speaking today as Dr. Volpe has invited, and thank you for that invitation, on a data-driven approach to stroke prevention. Here are some of my CME objectives that I would like to achieve in the next 20 minutes or so. At the end of my talk, I would like the audience to understand why stroke prevention continues to be the fundamental focal strategy for reducing global stroke burden. I would like the audience to be able to define and identify themselves with certain stroke prevention paradigms, understand the challenges, overall broader challenges in healthcare digitization, identify the sources, strengths, and limitations of the so-called big data for stroke prevention and outcomes research, and familiarize themselves with an integrative approach to data-driven stroke prevention and outcomes research. So at the beginning of my talk, I would like to pose this question as far as stroke burden is concerned. And instead of answering this question, I just want to share some facts. And we'll see these facts a number of times, especially when we are talking about stroke or we go to stroke conferences, and sometimes we become a little insensitive to these facts. And when you see these facts, please also keep in mind that during the last decade or maybe two, there has been tremendous advancement in treatment of stroke. So we have decreased the stroke mortality, we have improved stroke outcomes, but the fact remains that in 2018, a stroke accounted for 1 in every 19 deaths in the United States, killing 129,000 people per year, which translates into that a death from a stroke every 3 minutes and 33 seconds. At the global level in 2019, there were 6.6 million deaths, which were attributed to stroke, equally high for ischemic stroke or intracerebral hemorrhage or hemorrhagic stroke. And the 6.6 million, just to kind of put it in context, is a population that is bigger than the total population of several countries across the globe. And all of this translates into stroke contributing to more than 11% of total deaths worldwide. Of course, this is pre-pandemic data. What is also very remarkable is that the disparity of the burden of a stroke is not the same for all the populations. The lifetime risk for a stroke among women between the ages of 55 to 75 is 1 in 5. And it is a fact that stroke kills twice as many women as breast cancer does. There are widespread disparities which have been avidly reported in literature among minorities, among rural populations, and globally if we look in the low-middle income countries. 1 in 5 stroke survivors continue to live with moderate to severe functional, cognitive, or physiological disabilities, and only 10% stroke survivors make full recovery. The costs are staggering, as I'm presenting here, which runs in billions of dollars, direct and indirect costs for stroke care, and projected to be in trillions of dollars in foreseeable future. And so, going back to the question and thinking about it one more time, that despite of the advances that we have had in stroke treatment, acute stroke management, improving our systems of care, this is a clear and present burden that we face from stroke, and hence prevention really is the fundamental strategy that is going to reduce this burden. When we talk about prevention for a stroke, the basic paradigm is when to intervene. And I don't need to go into a whole lot of detail. Primary prevention, of course, prevents the event from happening in the first place. And secondary prevention, as the topic of this session is let's not make sure that it does not happen again. And that pertains to secondary stroke prevention. There are American Heart Association and American Stroke Association guidelines, and the focus of my talk is not to go over those guidelines, but just kind of highlight that when we think about prevention, we kind of have to think when we are intervening. What to target? There has been a lot of work done on modifiable and non-modifiable risk factors for a stroke, which I have listed over here. This is by no means a comprehensive list, but thinking about this in the modifiable versus non-modifiable is a good way to think about of where we can put an effort in stroke prevention and what benefit are we going to get out of that. And these modifiable and non-modifiable risk factors have been sort of studied really well. What I'm highlighting here is a 2016 case-controlled study called the InterStroke study, which was actually modeled after an InterHeart study in which risk factors for a stroke were determined. And this was done across 32 countries where risk factors were compared across about 13,000 cases and controls. And what ended up happening is that there are 10 potentially modifiable risk factors that accounted for greater than 90% of population attributable risk, which are highlighted in this forest plot on the left side of your screen. The take home really is that a lot of these risk factors are overlapping, and a lot of strategies that can be used sort of address those risk factors. So we talked about when to target and what to target. In terms of who to target, there are two primary strategies in stroke prevention that are practiced. There is the high-risk approach, and then there is the population-based approach. In the high-risk approach, high-risk individuals are generally identified, and personalized risk assessment and personalized prevention strategies are applied for these individuals. They often involve aggressive pharmacological intervention, and there is literature on that approach. And then in the population-based approach, the strategy is to target the entire population, and this is a health systems-based approach, which includes mass mobilization, awareness, and even legislation. However, I think the growing paradigm is that the approach has to be a hybrid approach. And this is a really nice publication by Valerie Fegan and his colleagues, which have highlighted how this approach can be instituted in populations and across individuals. And I encourage anyone who's more interested in this topic to kind of browse through this resource. I will now shift focus and talk just a little bit about where we are in terms of digitization of healthcare and how do we use data to sort of inform us better on the paradigms that I talked about in my earlier part of the presentation. So I think we all realize that healthcare is on a precipice of a data revolution. As an industry, however, healthcare, as compared to other industries, healthcare ranks really low on something that has been defined as a data quotient. And data quotient is a function of data as an asset, data skills, to which I add data infrastructure, and data utilization. And what I really mean is that data asset potential of healthcare is enormous. And what I've tried to highlight over here in this graphic is that there are several sources of data that can be utilized to inform us better about stroke risks, stroke prevention, and stroke outcomes. However, in healthcare, the utilization to asset ratio is really poor as compared to other industries, because most of the utilization is kind of stuck in this lower left-hand corner, and then we have not yet completely exploited the potential of data of health of data asset in the health sector. And why do we have that? Well, there are certain very concrete factors why do we have that. In most healthcare organizations, data sort of tends to live in silos. These could be inter-institutional silos, or these could be cross-institutional silos. And then on top of that, healthcare industry has a resource constraint as compared to other industries. And the reason why we have that, part of it has to do with the data ownership, part of it has to do with data privacy, liability, and the capacity of healthcare organizations to be able to utilize these data. So that is sort of laying down the problem. But now moving on to what can we do about that problem, there are several sources of data that are out there that we can actually utilize, and we have utilized, and I'll come to those examples in the last part of my presentation, for informing us better about the risks and about the outcomes. And what I'll be talking about in the next few slides would be using data from randomized control trials, using data from prospective observational research studies, utilizing data from disease-specific registries, utilizing data from national surveys, and lastly, exploiting the administrative data and EHR data to give us some insights. As far as randomized control trials are concerned, we know that there are several advantages of using RCT data for secondary data analysis, which include that the populations have a very specific disease phenotype. There is rigorous ascertainment of outcomes, and several effects can be explored, which include the intervention, and multiple randomized control trials. Data from multiple randomized control trials can be pooled to meta-analyze those data. The disadvantages are that these are not population-based data, and there's a lot of selective kind of process that goes for patients to go into randomized control trials. There is a need to account for the intervention effect, but generally what is done is that the data from the control arms can be pooled together, and because of their heavy resource requirements, they usually have modest sample sizes as compared to other sources. But if someone is interested, there are sources out there for randomized control trial data use. NIH has made this tool available for archived clinical research database. One can actually go in and search for the clinical trials for which the data are available. And another example is this Vista consortium, which is a UK-based consortium, but it pools clinical trial data. And we and colleagues have used this in the past to gain insights into stroke prevention, stroke risk, and stroke outcomes. As far as observational research studies are concerned, observational research studies have an advantage that they have prospective enrollment, they have prospective ascertainment and follow-up, and hence the assessment of risk and incidence is possible using prospective observational research data. There is usually very detailed assessment, and multiple outcomes can be explored, and they are often less selective than clinical trials. However, as compared to administrative data sources, they too have a smaller number of participants and patients, and the problem of differential loss to follow-up and incomplete assessments can sometimes make it challenging to gain insights into true insights into the risks and outcomes. However, there are several observational research studies that have been done, that are ongoing for several decades, and the amount of contribution of these studies is enormous. So from something like Regards, there are 600 plus publications. From something like the ERIC study, there are probably thousands of publications. Similarly from MESA, from Northern Manhattan study, from the Greater Cincinnati, Northern Kentucky study, the Framingham Heart study. These observational studies have contributed massive amount of information and evidence regarding stroke risks and stroke outcomes. Then there are disease-specific registries. The advantage of having a disease-specific registry is that there is very well-characterized disease phenotype data, which may include some prospective data as well. However, a big challenge is maintaining data quality, standardization of data definitions, and validation of data that goes into these registries. They generally require a lot of resource to set up and maintain. It is very difficult to get funded just for collecting data. The variability in follow-up information is there if there is lack of standardization, and those are some of the challenges with disease-specific registries. Nevertheless, there are several examples where disease-specific registries are present, and I'm displaying just some of them over here. At our institution also, we have the HOPES registry, which is a very well-characterized, well-phenotyped registry for our ischemic and hemorrhagic stroke patients, and has contributed significantly to the evidence that is out there. I'll just speak a little bit on surveys. These are usually nationally representative surveys, and that's the advantage of using data. Some outpatient data may be available if the surveys are conducted from patients or their families and that information is obtained. They can allow for a longer time span of available data, so trends can be studied. However, usually they are not longitudinal follow-up data on individual patients, and generally they have relatively low characterization of clinical phenotypes because these are mostly individual-based assessments, and so those are the major limitations. However, there are potential sources out there for these surveys, and studies have been done from the surveys to ascertain stroke risk and stroke outcomes. Moving on to the last part, the administrative and EHR data. The advantages of administrative and EHR data is really strength in numbers. So there is usually adequate power to study rare diseases, and they can be population-based. And a population I put in quotes because it could be a population, universal population of all hospitalized patients. They may have a longitudinal component to them because limited linkage is sometimes also possible. However, this longitudinal component is almost always not systematic because it is an EHR based on administrative data source, and it is limited and sometimes not fully validated clinical phenotypes because most of the times the clinical phenotypes that we have are administrative code-driven phenotypes. They usually lack certain essential data elements like laboratory values, like medication or imaging data. However, if we combine that with EHR data, some of that might be possible to include. Here are some of the sources for administrative and EHR data. And again, a lot of work has been done. We have done some work, and colleagues have done a lot of work in this area to generate actionable evidence for a stroke risk, for stroke readmissions, for phenotyping, and other endpoints. Lastly, what I would like to highlight is that given all these sources of data, I think the best approach is to not think about an individual source, but try to establish data pipelines that would link across these sources, sort of harmonizing them as best as possible so that the strengths of all the sources can be used in giving us insights. And this is a recent publication in Stroke which talks about some of those approaches. I will not go into a whole lot of detail. What I want to share is how we have implemented this approach, or how we are continuing to implement this approach at our institution. So what we have done at the Center for Outcomes Research is that we have established a neurological outcomes registry for patients with intracerebral hemorrhage. This is an administrative and EHR-based registry in which we have done work to phenotype the intracerebral hemorrhage patients based on their imaging data, which is sort of like the gold standard for identifying ICH patients. And we have developed, after importing that data through what is called an ETL, extract, transform, and load process, we have developed different dashboards for visualization of these data, which I will share just a few of them. So for example, we can look across our hospital system, we can identify the number of patients, we can look at their basic demographic data, we can see what is the geographic distribution for these patients is. We have all the imaging, we have incorporated all the imaging data so we can see the location of the bleed, we can see the size of the bleed, we can do certain other more detailed markers for small vessel disease in intracerebral hemorrhage patients, and a lot of that work has been completed. Similarly, we can look at certain outcomes, we can look at length of stay, mortality, different types of stroke that they have. And just to kind of wrap it up, the approach that we have is this integrated approach where we have structured EMR data, we have unstructured data. We are bringing in imaging. We have a virtual ICU physiological computational data, outcomes data that is prospectively being collected on these patients, and external linkages to CMS and other payer types. And finally, we have certain specific disease registries that we are cross-linking that. And the idea is to utilize the institutional investment in cloud computing and take this platform into the cloud so that more development on the analytics side can be done. So I hope with this talk we have been able to appreciate why stroke prevention continues to be our fundamental focal strategy, identify a few prevention paradigms, understand the challenges of healthcare digitization, and identify a few sources and their strengths and limitations as far as using data for developing stroke prevention insights are concerned. I thank you all, and thank you again for the invitation. That's the end of my presentation.
Thank you. Thank you. This is a very interesting approach to think about health prevention strategies. Traditionally we think about the Framingham Heart Study when you think about prevention and evidence-based prevention. And now, we're in this new big data era, and just kind of having these kind of systemic ways of approaching data assets. These are the new terminologies now, because the way of thinking and research has kind of shifted because we have so much data. But how do you take this data and enable us to utilize it clinically for prevention that is also evidence-based? Because traditionally evidence-based is kind of like the older ways of doing data, or they're obviously very important and still will continue, but there's these novel ways. How do we make sure that they're actually evidence-based with all of this data from many, many sources?
Right, so that's an excellent question. So I think the integrative approach is where we need to focus on. And as I was sharing, that we need to take the strengths of these different sources, integrate them together, and the data teams, the clinical teams, kind of need to come together and work together almost on a continuous basis. As you mentioned, Dr. Ahmed, the paradigm of evidence generation, which is a gold standard randomized clinical trial, it has a lot of latent period in that. In getting a trial started, in implementing a trial, in getting the findings, and then implementation of that finding is called that latent period of about 10 years, where a randomized clinical trial-based evidence can be generated and implemented. So what we have been focusing in the institution a lot is the terminology of a learning healthcare system. And the learning healthcare system approach really allows us to continuously integrate these data, develop pipelines which are validated, generate evidence almost continuously while we are providing care, simultaneously, implement that evidence and monitor that. And that is a very quick check on the validity of that evidence. Mm-hmm. So where we have good clinical equipoise, we can take that evidence, we can implement that, and we can monitor that and tweak that. But we believe that this is possible through this sort of learning healthcare system data approach, where we have such disease-specific, domain-specific, but big data sources that can provide us with those kind of insights on a rolling basis, day to day. Mm-hmm. The business of evidence generation and implementation cannot be separate from the business of providing care to patients. Mm-hmm. They have to kind of come together and move forward alongside one another.
Yeah, I think that kind of brings to mind Dr. Wang's earlier talk with AI. Uh-huh. So is AI is one of the ways this data approach analysis is being utilized?
The AI is definitely a very important part of the analytical platform that we built. Mm. Right. So there's a lot of infrastructure building that needs to happen for the AI to come in and be able to do its work. So because it is intelligent, but it gets fed some substrate. Mm-hmm. And we have to make sure that substrate is valid, and it needs to be what it is for the AI to be able to then do its function.
Makes sense. Otherwise,
right.
It wouldn't. You need the substrate to be valid, so we can move forward. Well, this is really interesting. Thank you.
So much.
Really enjoyed it. And not surprisingly, Dr. Vahidy's favorite subject in high school was physics. And so kind of made a whole loop in medicine back into physics here. So the new frontiers.
That is very true.
Thank you.